day in an important way. And so yesterday I sort of talked on the fact that if you understand pain physiology, it's kind of straightforward to understand why analgesics do what they do and why certain analgesics are better than others. So today I'll be talking about anesthesia, and the contrast is basically for general anesthesia, you're talking about loss of consciousness. And unlike pain physiology, we understand almost nothing about the physiology of consciousness. So what constitutes consciousness or unconsciousness, and what are the relevant pathways involved, and what's the relevant physiology involved. And so, because we don't really understand much about that, it's sort of difficult to talk about why general anesthetics do what they do with respect to the physiology, because we really don't understand the underlying physiology itself. And so because of that, most of the drugs that are useful general anesthetics were discovered by serendipity. So in the mid-19th century, a number of compounds were discovered by purely by chance to be general anesthetics. And so before anesthesia emerged as a practice, as you can imagine, surgery was very rare. So surgery was only done under extreme circumstances, like in wartime, amputate a leg or something like that. Basically, the method that they used was to either get the patient drunk. You've all seen the old movies where you get the guy good and drunk, you want to remove a bullet or you have to amputate the leg, and so forth, or hold them down. And so for a long time, that's what you did. So if surgeons wanted to perform surgery on a patient, they typically do one or both of those two things. So they use alcohol to sort of sedate the patient and get them out of it. Relax, don't need, is physically restrained. So it was in about the mid-19th century, the 1840s, that a couple of compounds became recognized that they would alter the state of consciousness. And the first one was nitric oxide, and it was there was a dentist who noticed that when people would take nitric oxide, actually people would inhale nitric oxide for recreational purposes. So they noticed the person would be kind of loopy and silly, but this dentist was around and someone was doing this, and the person cut themselves, and they actually cut themselves really badly, and they felt no pain at all. They didn't even stop doing what they were doing. They didn't change their mood. They didn't scream out in pain. They were just moving right along. So the dentist got the idea. Well, pulling someone's teeth without anesthesia is kind of tough. So they didn't know about local anesthetics at the time or anything. So he got the idea that if I could put my patients under nitrous oxide, I could maybe pull their teeth without them trying to bite my fingers off. And so that worked. So that was the first instance of general anesthesia. But that wouldn't work for complicated surgical anesthesia. So sometime later it was discovered that ether would induce full unconsciousness to the point that you could actually perform an operation. And that was actually discovered by a second-year medical student at Harvard in the mid-1800s. There was a famous demonstration at Massachusetts General Hospital that he put this patient under ether anesthesia in this full room. The faculty and the surgeon performed a complex surgery on this patient, and the patient didn't wake up, they didn't scream out, and that's the first instance of general anesthesia. So our understanding of exactly what these drugs do hasn't really moved very far in terms of physiology. We know some of the molecular targets, which I won't go into, but because it's very controversial as to what their actual molecular mechanism is. So that's a little bit of the backstory of the field. So anesthetics are divided into two general classes definition of general and local anesthesia is given here. So general anesthesia is the drug-induced absence of the perception of all sensations. So perception is the key word. Doesn't mean that you shut down all neural activity, but your perception of all sensations is gone, not just pain. So your perception of light, sound, pain, everything is completely gone. As opposed to local anesthetics, loss of sensation locally by interruption of nerve impulse. So on the exam, I'll ask you for these two definitions. You can just spit those out verbatim. That's one. But it's important that you be able to know that general anesthesia is not just loss of pain, it's loss of the perception of all sensations. That's an important definition, an important distinction. So, general anesthetics broadly fall into two categories, inhalation and intravenous. So inhalation anesthetics are obviously volatile gases. The two that are most commonly used now are isoflurane and sevoflurane. So over many years, the gases that are useful anesthetic agents have been modified chemically, and these have been found to be almost safe relative to other agents. And then you have a whole list of different classes of drugs that will serve as intravenous anesthetic agents. And these are usually used for either surgical cases that are minor surgeries, very quick, don't last very long, or for non-surgical anesthesia, so radiology procedures, common diagnostic types of procedures like endoscopy or colonoscopy. So these are the different agents that are used, and I'll talk some about the properties of those and when they're useful, and combination of them that are useful, and the properties that they use. So as I said, the discovery and development of inhalational anesthetics started in the mid-19th century. We discovered nitrous oxide by dentists, and then moved on through the discovery of diethyl ether. Sometime later, chloroform came into use, and its use did not last very long because it was found to be extremely hepatotoxic. The problem with nitrous oxide is that you could not achieve surgical plane of anesthesia. So you can do things like extract teeth, you can do some minor surgeries. It's better than nothing, but you can't really achieve a full surgical plane of anesthesia if you want to do complex surgery. With diethyl ether, you could. The problem with diethyl ether is that it's extremely flammable, which is a huge problem, obviously. So if chloroform came around, its use did not last all that long. And it wasn't until the mid-20th century that a non-flammable, relatively safe anesthetic gas was synthesized, and that was halothane. So halothane became the anesthetic of choice for nearly 40 years. And it was eventually replaced by derivatives that are similar in fluorine, and now, as I said, isoflurane and sevoflurane. And halothane is no longer manufactured. It's actually no longer approved for use as an anesthetic. And for reasons that are not understood, there's a high incidence of malignant hypothermia that develops with halothane anesthesia. So malignant hypothermia is a condition when under anesthesia, as it sounds, your body temperature starts spiking. It spikes in a very uncontrollable way, and it spikes to the extent that it will cause severe brain damage. That's why it's called malignant hypothermia. And halothane has a relatively higher incidence of inducing that in these other compounds. These other compounds are much less likely. drugs have some irritation of your airways, and that's less so with sevoflurane. So now in operating rooms, it's probably about 50-50 between isoflurane and sevoflurane. We do a lot of surgery in our lab, and we use isoflurane anesthesia all the time, so that's common. Sevoflurane is relatively new, which means it's very expensive. So typically isoflurane is favored most of the time over sevoflurane, simply because of cost. Certainly why we don't use sevoflurane. So the factors that influence, so obviously the goal when you're putting a patient or an animal, in my case, under anesthesia, is to achieve therapeutic levels of gas in brain tissue. So there are a number of things that factor how rapidly and efficiently that occurs, and it's all fairly simple. So the concentration in the inspired gas, which you have very good control over. And then the pulmonary ventilation. So if you have a patient that has very poor pulmonary ventilation, like a patient has emphysema or other lung problems, it's going to be difficult to put them under. It's going to take a lot longer, and that's the problem. So you get the gas into the airways, into the lungs, and the transfer of gas has to go from the alveoli to blood, and then from blood into the various tissues. For general anesthesia, the tissue of interest is obviously the brain. So all of these processes are constantly in equilibrium while you're trying to keep the patient on. And so the thing that mostly determines how quickly the patient becomes under general anesthesia are the levels of the brain. And so once the gas reaches the blood, there's this equilibrium between the brain, the blood, and all of these other tissues. And all of the other tissues other than the brain comprise a huge depot of drug for the anesthetic gas. So when you're trying to induce anesthesia or put someone under who's fully awake, you first have to fill up this huge depot before you can achieve therapeutic levels of drug. And so at levels that will maintain anesthesia, this occurs very, very slowly. So typically what you do to start with is you start off with really high levels of anesthetic gas saturated into the inspired air. You rapidly fill up the drug depot, and then the animal becomes unconscious. And once you've filled up the drug depot with these really high concentrations, then you back off on your anesthetic gas, and you can maintain general anesthesia at very low levels. So you sort of force the equilibrium this way by using relatively high amounts of drug initially. Once you fill up the depot, and you can maintain anesthesia with relatively low levels. And so if any of you have done any surgery in the lab, you understand this very quickly. So typically a 5% saturation, so of the inspired air, 5% of the air is anesthetic gas. That's typically a very high concentration for any anesthetic agent. That will rapidly induce anesthesia, and then you back off to lower levels, which equilibrates, and then you can maintain that state. And so you can put an animal under a 5% saturation in about 2 or 3 minutes. If you try to put them under initially at 2 to 3% saturation, it will take a couple of hours. So that tells you how large the drug the tissue of the fat is. So the thing to understand about dosing of inhalational agents is that therapeutic window is very, very low. So even with the agents that are used today, you can completely shut down breathing and cardiovascular system at only 2 times the effective anesthetic concentration. So as I said, you can maintain anesthesia at 2 to 3%. If you induce an animal at 5% and you walk away, you come back 15 minutes later, that animal's so the therapeutic window is extremely, extremely low. And the equivalent of the ED50 for anesthetic agents is what's called MAC, minimum alveolar concentration. So, as you know from pharmacology, ED50 is a dose of drug that gives you about 50% of the maximal effect. The MAC is the concentration that will produce immobility in the presence of a painful stimulant in half of the patients. So this is sort of an operational definition, and it's sort of a rule of thumb that anesthesiologists use if they know the MAC, and it gives them some idea of the potency of the drug they're administering. And again, the dose effect curves are extremely steep. So at 1.0 of the MAC for any given compound, about half of the patients will be anesthetized. If you increase that half log unit to 1.3, then virtually 100% of the patients will be anesthetized. So the dose effect curves are extremely steep for these drugs. The reason they're safe is because they're gases. So if you're administering these drugs and the patient stops breathing, their heart slows down, if you just remove the anesthetic agent from the inspired air, then you can quickly recover. The patient recovers. So their margin of safety relies on the rapid removal of the agent. In fact, you have such precise control over that. So that's sort of what mostly we understand about inhalational agents and their use, factors that affect their safety. So in the lab, we want to anesthetize an animal to do surgery. We just take the animal in, put them in a chamber, induce them on high doses, 5% isoflurane, put them under, and then we put them on a nose cone and maintain them at about 10%. With a patient, you don't do that. You don't take a patient that's fully conscious, but wheel them into the operating room and stick an isoflurane anesthetic. So there are a lot of pre-anesthetic agents that are given. And the role is, number one, to reduce anxiety. And typically, short-acting benzodiazepines are given. So as you know, these are the typical anxiolytics. Two are used. Midazolam or Versed is the most popular one because it's very short-acting. So it's rapid onset, rapid offset. And then Valium is still used, given IV or orally, to reduce anxiety. Opioids obviously are given to reduce pain during surgery or even prior to surgery if the patient has significant pain, and that's why they're coming in. The inhalational anesthetics will make you nauseous. A number of drugs are given to reduce nausea. So antihistamines, I talked yesterday about promethazine or Phenergan. That's an antihistamine. It's given frequently before or after surgery to reduce nausea. The one that's given a lot now is ondansetron. So it's a 5-HT3 antagonist. It's very, very good at reducing nausea. The difference is that this is not sedating. So ondansetron is not sedating promethazine. So the reason that you give these agents is that it's easier to induce anesthesia in patients if they're not in a lot of pain, if they don't have a lot of anxiety, because those things are alerting, and so they increase activity in the nervous system. You have to overcome that with anesthesia. So these drugs are frequently given before general anesthesia is attempted because it just makes it go so much smoother. Patient will reach anesthesia very quickly, and then it's easier to maintain the anesthesia for the duration of the As far as during surgery, if you're anesthetized, there are a number of things that you don't do. secretions, and mostly that's saliva they give muscarinic impact. That's a parasympathetic mediator. So you block that with muscarinic impact. So you should know which drug classes are given, in addition to inhalational anesthetics and why you give them, what role do these drug classes have around the general anesthesia. A number of other agents are given during anesthesia, and these are called paralytic agents. So they all do the same thing. So they inhibit the nicotinic cholinergic receptors at the motor. So I don't know how much of the you've been given on nicotine cholinergic receptors. There are several types, and the types of receptors that make your muscles respond to acetylcholine are a specific type of nicotinic cholinergic receptor. And so I think most of you probably heard of curare as a naturally occurring toxin, which blocks nicotinic cholinergic receptors that exist on motor neurons. Vecuronium is a derivative of that is used most commonly. And so they serve a couple of purposes. One is they reduce muscle rigidity, so if you're performing surgery, say on someone's leg or skeletal muscle, once you put a person under anesthesia, it's just a lot easier if that muscle isn't tight and rigid. So these compounds reduce muscle rigidity. They're used a lot for GI surgery. So one of the weird things that freaks people out, if you notice a surgery, particularly a GI surgery, put the patient under, happens at rats too, it's weird. You cut up in their abdominal cavity, and the intestines are just wiggling around, so they're all moving. And that's just a normal response. Your intestines are moving all around. So it's very, very difficult to operate on something that's moving and squishing all around. So they typically will paralyze the gut muscles using that. So the problem with using any of these agents is that they paralyze the diaphragm. So the diaphragm is obviously the muscle that when it contracts, pulls downward, and it creates a vacuum which causes your lungs to expand. So if you're going to paralyze muscles, you're going to paralyze the diaphragm. So the patient's not going to breathe. So you can only use paralytic agents when you're actively ventilating the patient. So the patient has to be intubated, and you have to have a machine that's breathing for it. So the patient has to be intubated at all times when you're using these compounds. So I'll talk a little bit about the different classes of intravenous agents. And these are agents that are used to induce anesthesia, and they will induce anesthesia. They typically do not induce a surgical plane of anesthesia by themselves. And so if they are used during surgery, they're used with other compounds, and they're used for very short procedures. So for barbiturates, the ultra-short-acting are the most useful. Pental and Hexatol. Hexatol is also called Revitol. It's used quite frequently. They're given IV. 10 to 20 seconds after you inject it, the patient will be fully unconscious. And it'll last about 20, 30 minutes. And so these are frequently used to induce anesthesia prior to inhalation. So if you ever breathe in an inhalational anesthetic, it's very costly. I mean, it feels weird, and it's very irritating. So it goes a lot easier if the patient is under before you even put that in. And again, they're used for very short procedures, but they are useful in certain circumstances. Talked a little bit about benzodiazepines. The properties that make them useful as anesthetics is that they're sedative and they're anxiolytic, and more importantly, they're analgesic. So they reduce retrograde amnesia. So you can can't achieve a surgical level of anesthesia. So if you're just sitting there and someone gives you Versed, you're not going to remember anything. But if all you've had is Versed and someone cuts your knee open, then you're going to you're going to come out. The good thing is it has very little effect on respiration or the cardiovascular system, which makes it a nice drug to give with ventilation anesthetics. And the problem is that if you combine it with opioids, you get severe respiratory depression, which is a problem. Again, as I told you yesterday, you're going to die from opioids, you're going to die from respiratory depression. So it potentiates that effect, even though it doesn't really do it. They're very useful as sole anesthetics if you're not going to have surgery, so it's not going to induce pain, so you don't need analgesia. And those are, the GI procedures. So it's very safe for that. It's very effective for that. You don't remember any of it, which is pretty important when people are putting cameras where those cameras go. And again, the two that are most popular again is Valium given IV, has moderate duration, and then midazolam or Versed is very short acting, so it's rapid on, rapid. Opioids are given. You can achieve a surgical level of anesthesia with opioids, particularly if you combine them with either nitrous oxide or paralytics like vecuronium. Obviously, for reasons that are hopefully clear to you, you have to artificially ventilate the patient when they're under these very high doses of opioids. And they're particularly useful when you're doing cardiac surgery. Surgery in and around that area induces a tremendous amount of pain. So opioids are typically given at fairly high doses. Again, you have to make sure that you breathe for the patient. Neuroleptic drugs, or another word for antipsychotics, are given as anesthetic agents, usually along with an opiate. So droperidol, which is similar to haloperidol, is a non-selective dopaminergic antagonist, is useful when giving with short-acting opioid like fentanyl. So fentanyl is an opioid that's rapid on, rapid off. And that combination is called Inovar. There's a veterinary form of that called Hypnor. So this is very useful, and particularly in infants or neonates, this can be given for very short surgical procedures because it's relatively it does produce a pretty mild anesthesia, so it's a surgical procedure. It has to be relatively mild and not very long lasting. Ketamine is a drug that is used as an anesthetic. It's a dissociative anesthetic. Dissociative means that when people are under the influence, they sort of feel like they're not part of their body, so it induces this bizarre psychological state. It's frequently used with benzos like diazepam for trauma or emergency procedures. Again, it's used a lot. It's more commonly used in children than in adults. The combination is frequently used for radiology procedures in children. So again, it's a non-surgical procedure. It's relatively rapid acting. It's relatively safe. Propofol is the drug that Michael Jackson was having an anesthesiologist administer to him so he could sleep at night. And unfortunately, the anesthesiologist set it up and walked away for about an hour. So it wasn't a good thing for Michael Jackson. Normally, if you're using it the way you should use it, it's pretty safe. It's fairly safe. So rapid induction and emergent from anesthesia. It's extremely lipid soluble, so rapidly goes into the tissues of the brain. It's frequently given with opioids, and it does produce significant respiratory depression if you're not paying attention to what it is. And it's frequently used for very short procedures. It's become one of the drugs So, so that's the part of the lecture deals with general anesthesia. So the non-inhalational anesthetics is sort of important to know when they can be used and when they can't, what they're used, what properties may be used. So local anesthetics, again, the difference between local and general anesthesia obviously is that for local anesthesia, you're basically just shutting down nerve conduction. And these compounds, and they're various compounds, they all do the exact same thing. That is, they block voltage-gated sodium channels. So from your neurophysiology lecture, you know that voltage-gated sodium channels are critical for the propagation of action potential along the neuron, along the axis. So these drugs very effectively block those channels, and therefore the action potential is not propagated. So you just shut down. The first one that was discovered to do this was cocaine. Mid to late 19th century. Sets down a number of other drugs that have been synthesized that are similar to cocaine, use-related effects. So the distinction that I want you to make is that these drugs do selectively block voltage-gated sodium channels. They have no effect on ligand-gated sodium channels, like nicotinic receptors, for example. And they do inhibit the firing of all neurons, so they're not selective to sensory neurons, either pain transmission sensory neurons or proprioception sensory neurons. So even neurons that encode normal pain, pressure, temperature. So they inhibit the firing of all neurons, and because they block the channel, they bind to a site inside the channel. So the sodium channel has to open in order for these drugs to get to their site of action. For that reason, the blockade of neurons is frequency dependent. So the more the neuron is firing, the more of these voltage-gated sodium channels will be open at any given time. The faster the local anesthetic gets into those channels and can block them. So sensory neurons fire faster than motor neurons, and so that's why you administer these agents locally. You're going to get a sensory block before you get a motor block. You will eventually get a motor block. You'll eventually completely numb. So if you give it the finger, you're not going to move your finger, but it'll become numb before motor effects. So there are a number of different techniques by which you use local anesthetics depending on what you need to do and what you want to achieve. And so the most commonly used technique is obviously infiltration, where you just inject the drug directly into the tissue. So I had the good force of slamming my finger at the car door one time. And so in that case, you just inject the local directly into the skin, directly into the muscle tissue into the fingers. So that's the most common use. A field block is when you have a large area that you need to anesthetize. So you use subcutaneous injection. So if you have a huge incision on your arm, for example, you would do a subcutaneous injection as opposed to sticking it directly into the skin. And those are much less common. Nerve blocks are frequently used along with general anesthesia when you need to do a fairly complex surgery. So for nerve block, you inject the local anesthetic as close to the nerve or a collection of nerves. So nerve plexus is just a collection of a bunch of nerves that come together. So you inject the local as close to the nerve as you possibly can. And it's very critical that you get the local close to the nerve and not in the nerve. If you inject these drugs directly in nerves, you're going to cause nerve damage. So this is frequently done, but you use MRI to guide the injection, so you can't do some frequent. also will provide almost complete analgesia for several hours after the surgery. So a lot of times people come out of surgery and I had surgery. I had a total knee replacement. I feel great. I can run down the hall. 2 hours after that, the nerve block wears off and they're straight stuff to make this go away. So they're very effective. Regional intravenous anesthesia is not very common. It's typically used only in emergency types of situations when you need to just shut down all nerve activity, usually to an extremity. So, as I said, lidocaine will block every nerve. So, if you inject someone IV with lidocaine or bupivacaine, it's going to go straight to the heart and stop the heart. So you can't do that. So you keep the intravenous anesthetic local by applying the tourniquet. So it's only useful in extremities. So you can apply a tourniquet here if you need to completely numb up the hand for a very short amount of time. Then you can use it. And then spinal epidural blocks are very common where you apply the local anesthetic. Spinally, they need to shut down the spinal activity of the lower nerves that are entering and exiting the spine. So these are different techniques that are used with local anesthetics. Infiltration is by far and away the most common, followed by nerve block and spinal epidural. These other two don't occur very often. So, as I promised, today's lecture is very short. I wish there was more physiology and basic mechanisms involved, but that's where we are in our understanding of what these compounds do. Local anesthetics is very simple. General anesthesia, I want you to understand the basic principles and the basic classes of drugs that are used, either as anesthetics themselves or in conjunction with
Which two board?